Thank you for choosing Axxess On Demand. Axxess believes in continuing education, and we create content to empower you to learn and grow anytime, anywhere. Let's get started.
Welcome and thank you for joining Axxess and our panel of industry experts to hear their strategic perspectives on CMS's calendar year 2024 home health proposed rule. We're delighted to have 800 registrants for today's discussion, which will cover three different aspects of the rule. First, the impact of the proposed rule on home health providers and patients, the industry's proactive legislative and advocacy strategies to effect change in the language of the final rule, and provide actionable clinical and operational strategies that your home health organization can implement today to minimize the financial impact on your business. We will also hear about the importance of leveraging technology, provider compliance, star ratings, and accurate cost reporting to safeguard your business operations, not just in 2024, but into the next decade. Hi, I'm Deb Hoyt, Senior Vice President of Public Policy at Axxess, and thank you for joining us for this live web conversation. During our next 55 minutes together, the webinar questions feature will be available to you. We won't have time to address your questions in real time, but our panelists will respond to you by email. Early next week, all registrants will receive a link to today's recording, along with the slides and additional resources. So now it's my pleasure to welcome our three panelists. First, Andrew Woods. Andrew provides legal counsel, is a federal healthcare lobbyist, and is chairman of the Washington, D.C.-based Liberty Partners Group. Andrew is a longtime friend and ally of the home-based care sector, and we're delighted to have him working with us here at Axxess as our legal and policy advisor. Next, I'd like to welcome Bob Markette. Bob is a health law attorney at the Indianapolis-based firm of Hall, Render, Killian, Heath, and Lyman, with more than 20 years' experience handling operational, compliance, legal, and regulatory issues facing home care providers. And finally, my friend Arelene Maxim. Arelene is Senior Vice President of Clinical Services at Axxess. She's a national home health and hospice expert and author of the book, The Survey Trainer. So welcome to each of you. So Bob, let's start with you. Let's just jump right in. CMS released the calendar year 2024 Home Health Prospective Payment System Rate Update and proposed rule on June 30th. So the industry was holding its breath in anticipation of the release. Our national associations conducted a strong and unified 6-month advocacy campaign leading up to the release of the proposed rule to stop payment cuts. Needless to say, the proposed rule was a blow to the sector, and CMS handed us a negative 2.2 overall payment reduction and an additional proposed negative 5.63% permanent adjustment, among other things. So Bob, first, tell us a little bit about yourself, your work at Hall Render, and your expertise in the home health space. And then can you go on by providing us with your perspective of what these proposed rate reductions mean to your clients and the industry, particularly at a time when home health value-based purchasing is in place?
Sure. Thank you for having me. Very brief about me. I don't like to talk about myself. I've spent, excuse me, but more than 20 years now, and I know that because my daughters, who had not been born yet when I started with this industry, are now 20, and one of them has actually, as I've told Arlene recently, got engaged and joined the nursing profession. But in that 20 years, I've had the opportunity to work with the home care industry, home health, hospice, private duty, in a wide range of areas. So I get to deal with Medicare on a pretty regular basis, surveys, reimbursement, audits. Before I got into healthcare, I was a public defender, so I still like to dabble in the criminal world. So I'll help with fraud investigations and things like that. We do with OIG or Medicaid fraud control. And then employment labor, because one of our biggest areas, we're a service industry and we use our staff to take care of folks. So I do a lot of work with employment and HR type matters for my clients. I say that my subject matter is home care, not a particular legal subject, which differentiates me. Some of my colleagues still understand what I do because it's just home care. So that's enough about me. As for the rule, my first thought is, if you like change, you're going to love this rule. The problem is it's probably not the kind of change we were hoping for. As you said, we'd hoped through advocacy and otherwise to avert what CMS has been hinting at. Since PDGM came out, they've had the authority in the statute to make budget neutrality adjustments, and they made a big one last year. They threatened to. They kind of stepped back from it. They held off during the pandemic. They recognized we probably couldn't face that much turmoil all at the same time. But now here we are, and this is the second year they've proposed a budget neutrality cut, and it's a significant one. And so I think the big takeaway from what's in this rule, there's a couple of minor things I think are too concerning, but with the value-based purchasing and the reimbursement issues, I think uncertainty is the big issue for the industry, and that is, how's this going to shake out? Will this proposed permanent cut stick, or will they propose a bigger one last year and step back from it, or will they stick with it? But then the other thing is they keep talking about the temporary cut. Hey, we've overpaid you guys these past years, and they keep putting the temporary cut out there, but they can't quite bring themselves to pull the trigger. And so the question is, will that come back into play? And that's something, if it doesn't come into play this year, will it come into play next year? And that's for the industry, so we have to think about, because we have to plan. We have to plan ahead, we have to plan budgets, things like that. And you're looking at a significant rate cut in the midst of what's been, not necessarily record setting, but in the memory of most people, shocking inflation and wage pressures, things like that. The pandemic saw staff just leave, and they haven't come back. I've had many of my home care providers ask, well, where'd everybody go? And nobody knows, but what that's causing now is our employment costs are going up. As we're facing all these pressures, and CMS comes along with this rule to take money back. And then on top of that, they look at home health value-based purchasing that we're just getting used to. We just got through the first, we had the practice year, now we're in the performance year. And they want to not only change the metrics that are being used, and they want to take out 5 and replace them with 3, but they also want to change the baseline year. And I'm not a data expert. There's other folks I would defer to on that. But I think I know enough about math to know that baseline change presents a real problem, because it's, as I'm projecting the future, I'm thinking of these rate cuts and what those might look like for my operations next year, that I've got to think about value-based purchasing and where do I fit on that in the dog-eat-dog world of value-based purchasing, because it's not me against some absolute number, it's me against you, and we're all trying to fight to get ahead. But now you're going to change the measures and the baseline. So if I'm projecting out, what do I need to do to survive? I have all these variables I don't know. And I think there's a very strong likelihood that in the coming years, as long as CMS has the authority under the statute to engage in budget neutrality adjustments, that will continue. Now, that's not to say it's all doom and gloom. You might be thinking right now, well, they'll let Markette speak first because he'll scare us, and then we'll be much more likely to listen to everybody else, which I get accused of pretty regularly. But I do think there's some hope. One, CMS has traditionally come out, made a proposed rule that's very terrifying, and then backed away with the advocacy of it that we're going to talk about here later. With the litigation, NOC has already filed a lawsuit, which I think has some significant merit to it. And comes at a time when the federal courts have shown much more skepticism about government agencies and their power. And so I think we're at a moment where we may have some traction to push back there, because their methodology, and we'll get to the methodology questions later, is suspect. So this may change. This may be a case of we propose this terrible rule and come to the fall, because this rule made a lot more sense at Halloween if they're trying to scare us, but they may pull back because it will make them look more reasonable. So I think there's still that thought there, but then on top of that, we just have to plan. We've done this before. We have to sit down and figure out, how can we be more efficient? How can we use technology to improve our operations? What can we do in terms of cost? How can we attract staff knowing that we are somewhat limited on our ability to compete on wages? What other things can we do? And you see people talk about things we can do with our staff and our employees to do that. So there's things we have to do there. I think overall the rule really was a disappointment. I don't think, given the economy, given the metrics, given the things the Biden administration has said, I mean, they've been very big proponents of home care. They've took the steps with, there's a couple of executive orders and other steps focused on home care and expanding home care. And there's a Medicaid rule, all these things they want to do to make home care more accessible, because they seem to recognize, at least when they're speaking, we're the most cost-effective healthcare providers out there. We do more to save Medicare money than anybody else. And the thought there should be, you put your money where it's most effectively used. If you want to really help Medicare, if you want the hospital value-based purchasing, the AC, all these models to work, they should give us more money. And they seem to recognize that. But then we get this rule where they do the exact opposite, because they seem to think there's too many of us, we're making too much money. You look at the data they're relying upon, and we've somewhat done that to ourselves with cost reporting. The reason they think we have a 45% profit margin, which is essentially what they're saying, is because our cost report data is off. And they're using cost report data that precedes the last 2 years, right? They're talking about, they use the 2021 data, and we're in 2023. 2022, we had significant increases. I don't think the 2021 data necessarily reflects the staffing and other issues. So those things all come home now, where you've been telling us you want to help. You've been telling us we're the future, right? Many states are expanding home injury services because it's more cost effective. And then you give us this rule. And so I think there's going to be some discussions with CMS and with our elected officials. Congress needs to understand, look, you guys are kind of running out of money. And if you want this to work, you need us. If you want to keep people out of the hospital, if you want to reduce emergency room admissions and things like that, you have to keep us around and support us. And frankly, I've had conversations here in the state of Indiana with our Medicaid agencies. They're trying to find ways to expand home injury service, expand home health, find more money in the budget to do more, because they want to drive folks away from facility care into the home, because that's where people want to be. So I think this is where we find out, does I hate to say lip service, but does the lip service that elected officials and the White House, others have paid to us, do they now take stock of what they've done and listen when folks come in and say, hey, here's the reality on the ground. We can't operate. When nursing salaries are up 5, 6, 7% year over year, when our home health aides could come be home health aides with us, or go work at McDonald's or Chick-fil-A or the Amazon warehouse. The number of folks I know, because in Indy we have a ton of Amazon warehouses, and for all the bad press they get, they pay more than we can afford to pay, and they're hiring the same people. So if they really understand, like they say they do, I think we have some opportunities here in the coming months to avert this disaster. But then I think we have to think more about how we're doing our cost reports and how we're collecting that data, because at the end of the day, garbage in, garbage out. And if they've got bad cost data from us because we haven't taken those cost reports seriously, they're going to come up with these crazy numbers that show, well, we can afford to cut you guys by 6 or 7% because you have 45% profit margin, which if any on this call knows someone who's got a 45% profit margin, I would be surprised, because I think 5%, if you're getting 5% of a margin, you're doing exceptionally well. And yet that's not reflected in the numbers. That's not reflected in the data. And so CMS seems to have some misunderstanding of how we operate and our costs and things like that, which leads them to conclude we're being overpaid. And so we come here where they might, if I want to be generous, so if CMS is listening, I can be generous, they might honestly think we can afford this cut and that they're trying to save the Medicare budget. I just don't think they have an accurate assessment of our industry, and I think some of that is a self-inflicted problem.
Thanks so much, Bob. That was, you really laid out the land in terms of what the opportunities were, what the challenges were, kind of what our own pain points are as an industry, and maybe what we can do about them. So I think I'll move on to Arelene to expand upon that a little bit. You touched a little bit about compliance and technology. So Arelene, your work with home healthcare agencies across the country for the past 30 years has focused on clinical compliance, improving agency star ratings, leveraging technology to drive operational efficiencies and maximize revenues. So as we face another year of uncertainty around further Medicare revenue reductions, as Bob was talking about, what recommendations do you have for our audience that would position their businesses favorably right now, despite what may be ahead in the final rule for 2024?
Well, thank you, Deb, and thank you for this opportunity. Yeah, Bob, that was really a great overview. And I think that one of the things, and Bob alluded to it, is that we have to brace ourselves for change, and we have to embrace change in our industry. I think that a lot of the cost could go away using technology. We talk a lot about technology and the uses of technology. Agencies need to start investigating those possibilities. There is so much available to us now that we did not have 5 or 10 years ago. One of the things that COVID did do for us is allow us to get used to using technology to actually evaluate the care needs of patients and to do some teaching and that type of thing. One of the areas that really shocked me during COVID was how quickly physicians were willing to embrace technology. And I think that even though we as an industry are not being paid for much of the technology that's being used today, we have to start collecting that data and making sure that we have accurate data. One of the things, and I think Bob would agree with me, that we lost actually some leverage with was our supplies, because we were not tracking our supplies properly. And so now supplies are just kind of lumped in with our payment, our episodic payment. Same thing could happen with technology if we're not very careful. So I think we need to start looking at costs of technology. There was a report that came out not just in the last few weeks that indicated one, I believe it was an attorney group, found that some of the cost reports were indicating that the cost for a nursing visit was from 29 cents up to $79,000. Now that's a huge range, and obviously they had the information to support that. But Bob is absolutely right. The cost reports and what the data that goes into those cost reports. And one of the things that's happened to our industry was prior to 2020, before we went to PPS model, the cost reports were based on actual costs. And we spent months, the industry spent months on a cost report to get that data collected as accurately as possible, so we could submit to well, it wasn't CMS, it was HCPA at the time, but we could submit to the federal government, and we were actually paid based on those cost reports. So if Medicare owed us money, if we hadn't charged enough, Medicare would send us a check. If we overcharged, if we didn't spend as much as we thought we would, very much like a nonprofit would work. And so we got used to we spent a lot of money on cost reports. We hired the very best accountants. We researched the very best accountants. So we had every single detail covered in our cost reports. What happened with PPS, CMS came out and they said, well, you still have to submit cost reports, but we're really not going to look at the data. That's not going to be important. You have to submit them, but we're not going to do anything with them. Well, they have done something. And so MedPAC, who is the advisor for Congress, goes to Congress, and they give them all the data that they collect from the cost reports and from their analysis on what's going on with the industry. And there lies the problem. And this is how we have come up to where we are today. So many of the agencies after the year 2000, because the cost reports weren't really going to mean anything, decided that they would find an accountant, not necessarily even a CPA, an accountant that knew how to put the numbers in on a line, on a cost report, and submit it for them, but for the least amount of cost. And I believe that that's where our industry has gotten ourselves into a major problem. I think that we have looked at the cost of preparing cost reports and not looked ahead at what might possibly happen as a result of that, because CMS is seeing a huge range of profit margins. And like Bob said, they're talking about 45%. I don't know. And I work with a lot of I know about a lot of agencies, and I know no one who is working at anything more than even like Bob said, 5%. It would be generous. I don't think that's happening. So I do think we have to look at the way we're doing things now. We have to start looking at how to cut some costs. Technology can certainly do that. We have a huge amount of technology that's available to us to augment the clinical on-site visits that we do. But I also do think the other part of that is making sure that we have an accounting firm that we can trust, that knows the industry, not just any CPA or not just any accountant, but someone who knows the industry and knows exactly how to complete those reports, so that MedPAC and Congress does get a good view of what we're actually doing. We're doing a really good job, and we have to make sure that we're keeping these people out of the hospitals. Patients don't want to go in the hospitals, particularly after COVID. We know that institutionalization is not something patients want to have done with them. So we want to keep these patients at home as long as possible. We want to do the best job we can. We want to provide as much care as possible, and augmenting that care with technology and making sure we get the best statistical information out there needs to be at the top of our list of things to make changes with.
Thanks, Arlene. And as you'd mentioned, technology is really critical. And I think a little bit later in this webinar, I want to dig down in terms of asking about that. Sometimes people think about technology as telehealth, but there's so much more in terms of your EMR and some of the other things that you can do to make sure that you can leverage your day-to-day office technology to make sure that you're as efficient as possible. So we'll kind of back into that a little bit after we hear from Andrew Woods. So Andrew, you've been the face of the industry in Washington, D.C. You've been at the center of the National Association for Home Care and Hospice and Partnership for Quality Home Healthcare strategic advocacy work for many years, and we really appreciate your representation and the strength that you bring to us there with Congress and the administration. So can you tell us, let's step back a little bit, tell us about the advocacy pressure campaign that led up to this release of the proposed rule, then kind of bring us forward to walk us through the legislative and regulatory and litigation strategy that's currently being rolled out right now by those two national organizations, and what we're doing during these summer months during this CMS comment period to respond to the proposal as we lead up to the final rule, which will be released later in October.
Sure, Deb, thank you very much for the opportunity to participate today. And I don't know if it's been the best looking face to represent the sector all these years, but I've certainly enjoyed the opportunity to do so, and have worked with PQHH back since its founding days when Tony Strange and Keith Myers and April Anthony put it together, and then recently started representing NOC, working closely with Bill Dombey and his board. Look, this is a very frustrating time for everyone in home health. It is understandable for providers out there, large and small, to wonder if CMS and the Biden administration value what home health does. These cuts are really devastating, and in my 34 years of lobbying, I have really not seen any one sector come under such scrutiny and attack in terms of reimbursement cuts as I have home health, particularly over the last couple of years. What CMS is doing is really a de facto rebasing, which of course they don't have the authority to do unless Congress gives it to them. And they are relying, as Bob alluded to earlier, upon their interpretation of the 2018 BBA and their understanding of what budget neutrality means to come up with these cuts. So CMS is kind of like the self-righteous preacher you might hear who's absolutely determined that what they're doing is right. And really this process of fighting their interpretation of budget neutrality is one that has took place in the last Congress and obviously is going into this Congress. So some of the things that the sector has done before the proposed rule came out, we went to our friend Senator Debbie Stabenow of Michigan, longtime home health champion, and Senator Susan Collins of Maine, Republican, longtime home health champion. And they both introduced a bill before the proposed rule came out, as I said, to send a signal to CMS that this sector is ready to fight. Billy Tozan, a longtime member of Congress, closely affiliated with LHC, recently inducted into the NOC Hall of Fame, made some prophetic statements during his introduction into the NOC Hall of Fame. He said, you know, home health in Washington is very much respected, but not at all feared. And our lobbying has tended to reflect that over the years. Really going back to Val Halamadera setting up NOC, we've been reluctant to really pull the punches and fight hard on some of these rules as tough as, say, some of the other sectors have done. And therefore, I think sometimes CMS thinks, home health, you know, they're not the pushover, but there's room to cut there. They'll squawk, but they'll keep doing their business. And part of the strategy for the sector coming under the leadership of PQHH and NOC, you know, people like Keith Myers and David Beata and Ken Albert over at NOC and other NOC board members, led very well by, you know, Bill Dombey and Joanne Cunningham, was that no, we're going to make no mistake that this time CMS and the administration should fear home health. So one, we introduced a piece of legislation, a tough piece of legislation that simply says no more cuts, no more permanent adjustments, no more temporary adjustments. What happened in 23 is water under the bridge. but these members of Congress, Senator Stabenow and Collins in particular, said we've got to stop the bleed reimbursement for home health. That's number one. Shortly after the proposed rule came out, under Bill Dombey's leadership, and a committee of various CEOs who thought very carefully about the kind of law firm the sector should hire, what the complaint should allege, exactly what ought to be contained in the complaint, who the plaintiff ought to be. NOC did file its lawsuit to put CMS on notice that with respect to the argument about the interpretation of the methodology that CMS is using, we're going to let the courts decide that. And we happen to draw a judge in the District of Columbia, a Trump-appointed judge, who used to be a member of the Federalist Society, and while I'm sure he will be, very objective and exercise judicial conduct just like it should be, he does have a history of doubting some of these decisions of these agencies. So we were really lucky to get the draw that we did in terms of the federal judge who's going to oversee this case, probably in the next 2 years or so. So you've got a tough piece of litigation out there that CMS obviously knows that we filed. We've sent it to them, they're aware. And then just this week, we had our House companion bill introduced by Congressman Adrian Smith and Congresswoman Terry Sewell of Alabama, the Democrat, a longtime champion of home health. So you have two bills, House and the Senate, identical, say the same thing, no more cuts, stop the bleed. And then you have this very tough lawsuit. Now, I was just in Maine with Senator Collins this weekend, and she's actively helping us get other Republicans on our bill. We've had bills introduced in the past where haven't had a lot of Republican help on these reimbursement issues in terms of getting lots of co-sponsors. Senator Collins is just determined to get as many finance Republicans on this bill. She's determined to work with Ranking Member Crapo on the Senate Finance Committee, just as Senator Stabenow is with Senator Wyden, the chairman of the Finance Committee, to make this a #1 priority. Senator Stabenow is retiring from the Senate at the end of this Congress. So in January 2025, she'll be leaving. But she recently had a meeting with Senator Wyden where he asked her, said, Debbie, what are your top priorities from the Finance Committee before you retire? And she listed 3, and home health was #1. So the chairman's on notice that she's going to fight like heck, and she's tough. She's a very, very tenacious champion to have. And the same, the same in the House with our champions there. They'll work the bill very hard as well. Deb, for the first time in many, many years, we're going to have a hearing on home health before the Senate Finance Committee Health Subcommittee. Now that's chaired by Senator Ben Cardin of Maryland, who's been a strong home health supporter, and the ranking member on that is Senator Daines from Montana, who's a member of the Finance Committee. Obviously, he's also chairing the Republican Senatorial Committee. So he's the senator running the committee for Mitch McConnell that's trying to take back the Senate. And Bob alluded earlier to the Biden's commitment. I remember we all who watched President Biden's last State of the Union were surprised to see him kind of wing it on the floor and get Republicans to agree to a no cut to Medicare pledge. Well, if I'm Senator Daines, and I'm involved in this issue, and I see that this is in fact not just a payment adjustment, but a real cut to Medicare, fee-for-service home health. We know the number of beneficiaries have been declining the last 3 years. We know that the spend in Medicare on home health has been dropping. If I'm Steve Daines, I would take this and just ring it around the neck of John Tester, his fellow Democratic senator from Montana, and say, how is it that your president made us, the Republicans, pledge that there would be no cuts to Medicare, and yet he's cutting a very sector, which, by the way, Beata took care of President Biden's mother and his dying son, Beau. So this president ought to have a true understanding of what the value of home health because of his very personal experiences with it. There'll be a major grassroots campaign over the course of this month in support of both our Senate and House bill. That's why it was important to get both those bills introduced before the break so that Axxess and Beata, all the companies with a great grassroots network and smaller providers as well, talk to your members of Congress, refer to the bill numbers, say you support the Stabenow-Collins bill or the Smith-Sewell bill. Familiarize those members with the problems. And in August, when members are home and constituents who are watching this webinar can go to town halls or get meetings or just see their local members in the grocery store, jump on them on this and let them know how much this hurts providers and patients in their very own district. That's what grassroots is all about. Sometimes the grassroots done at home over an August recess is far more effective and impactful than what's well choreographed and organized in Washington.
Thanks, Andrew. I mean, it's so complex, and the interconnectedness between the policy piece of it and the politics piece we don't often see, but your insight into that was really helpful in terms of helping everybody understand everything that's going into this. I guess I want to acknowledge NAC and PQHH, Bill Dombey and Joanne Cunningham for their leadership on this, your work with that. I can't wait to have the Senate hearing take place and see what comes out of that. But the two pieces of legislation, the Senate and the House bills, along with all the work that's being done right now. And then you mentioned grassroots. I mean, to me, grassroots is the favorite part of what I do in terms of public policy. And here at Axxess, grassroots is critically important. We'll make sure that we get action alerts out to support what NAC and PQHH are doing and what you are doing on the ground. And you said that this is a congressional recess right now for the next 4 weeks or so. We'll make sure that we really get our voice heard. So I think that all of us coming together is really critical. The folks that are listening on the webinar, I mean, this is not external to you. This is very important that you just take 2 minutes and send an email to your legislator, and it's very easy and automated. So thank you for mentioning that, Andrew, and I really appreciate the work that you're doing. So that's terrific. I want to move on to Bob for a minute. Bob, you started out the conversation talking about kind of this CMS flawed methodology that's basically been producing these devastating cuts to Medicare home health. And Andrew just mentioned a lot of that. And then prior to that, Arlene was mentioning the cost reports and how that played in there. So I guess I want to ask you, CMS's own data shows that recent annual updates to Medicare's payment rates for 21 and 22 have significantly underestimated inflation and labor costs by more than 5%, resulting in significant underfunding necessary to provide patient care. Everyone on this call that's a provider knows that inflation and all of the other things that have played after COVID have really, specifically labor costs and getting the workers needed, is really a challenge. So, you mentioned before that home care saved the Medicare Trust Fund over $1.38 billion over the past years, right? So we're a cost saver. How do we turn CMS's policymaking around to adequately reimburse our Medicare home health providers in this final rule and moving forward?
Well, I think Andrew outlined the various approaches. I'd say the carrot and the stick approach, but there's no longer a carrot approach with CMS. It's just sticks, because we've tried to be nice, we've tried to be reasonable, but they won't listen. And part of it, I said this before, Arlene mentioned it, Andrew mentioned it. We've kind of put ourselves in bad position. It's hard to, essentially CMS is like, you guys are crying poor, but we don't think you're poor. Now, despite all the voluminous evidence to the contrary, just the fact that how do you last year and the year before and this year keep cutting us or giving us these minor, I think last year we got like a 1% increase, if I recall. Well, that's fine, but inflation's been above 3 or 4% for years, and wages have gone up faster. We've had municipalities for years now passing $15 and $16 minimum wages for living wage efforts that are not accounted for. CMS, in some ways, I tell people, when you talk about hospice, CMS still views hospice like it's 1979. When you try to talk to CMS about hospice structures, things like that, they don't understand that our cost structure today is not what it was in 1985. I can't go to the gas station. My kids make fun of this. I remember when I got my driver's license, a gallon of gas was 25 cents, maybe 27. And those days are over. And yet when we cry poor, they don't believe us. And part of it is because we have failed to give them good data. They rely on the cost reports. And so when they go look at the cost report data, what they see is what Arlene talked about. They see an industry whose data shows our costs aren't real. The cost reports, and I've seen this in Medicaid. In Indiana, Medicaid we had a similar issue, and they gave us the cost report data. And it was crazy how according to the cost reports in 2016, it was cheaper to provide home care than in 2010. And we're all like, that's mathematically not possible. So here it's the same thing. Last year, they said, well, there's a 34% difference between reimbursement and costs. Then you have 6% inflation last year, a minor, perhaps minor increase in reimbursement, but then we're now up to 45% difference. And it's the data. We've got to be better at giving them data. Even not just the cost reporting. For Andrew and Bill, Don, Evan to go to CMS and make the case that we need more money, we have to adequately show them this is what it really costs to do a visit. When there's a cost report, when cost report data shows a visit may cost as much as $79,000 or as little as 2 cents, it's hard to make a case to them. And keep in mind, CMS, to my knowledge, no one in CMS has ever had to make a budget, right? When you're the government, hey, we're not having money, let's print some more. They don't have the same concerns we have. And I don't think in a home care company, it's interesting that the supposed home care experts at CMS, none of them actually run home care. So they don't, I've talked to CMS regulators and outlined concerns about home health and hospice, and it's news to them because that's not what they do. They regulate, they don't operate. So we've got to be able to paint that picture, and that's the data is very important to do that, to get it correct in the cost reports, but then also to have it. So when Andrew goes to Congress, say, well, look, this is what it really costs. Nurses' salaries keep going up, and here's the thing: if you look at the demographics, nursing salaries are not coming back down because look at the demographics of the industry. There are far fewer nurses now than there used to be, and there aren't more coming. My daughter in nursing school would talk to her nursing professors would discuss that dearth of nurses. So that has to be made real in the data. And then I think the rest is just the other issue. CMS has regulated, and this is across the board, because of things like there's this case you learn in law school called Chevron, where the courts decided, it's just easier to trust the experts, the administrative agencies. So CMS doesn't get a lot of pushback. When we go to them, and I think this played into a lot of knock and the industry strategy about playing nice. I tell clients it's hard to fight against the administrative agency because the courts for many years like, well, they're the experts, we'll trust them. Well, those of us who deal with them, who read the content, if you've read this proposed rule and their discussion of our costs, and their discussion of how our costs keep going down and our profits keep going up, and then their discussion of the methodology they're using, where you read the methodology and like, wait, this is all circular. Like, this is a death spiral. Like, you guys keep kind of like, well, now we look at it and we recalculate, and now we're going to rebase everything, and the number keeps getting smaller, which is not budget neutral. Congress didn't tell you CMS price home care out of existence. It told you to maintain because of behavior, but costs are going to go up. Inflation, you should be getting more Medicare beneficiaries because look at the demographics of our population. But CMS seems to have a complete disconnect from that, and they get locked into their model. And this is the methodology, and this is how we've always done it. And it reminds me of a mock motivational poster I saw once about committees. There's this poster that said committee, had pictures of this beautiful boardroom and all these beautiful chairs. And the subtitle was, because none of us is as dumb as all of us. So the folks at CMS, they're hardworking. I've got a lot of folks I respect and enjoyed working with, but they get together and this is how they've always done it. And so here we are with a budget neutrality model where they told us 3 years ago, here are the behavioral assumptions. We think you're going to do these things and it's going to cause costs to go up 4.36% more than they would under this current model. Then they come back, and this is one of the big points in Knox lawsuit. But then when they came back to reassess, they didn't look at those three assumptions. They looked at all sorts of things. For example, therapy, we don't get paid for therapy anymore. Therapy cannot change the cost of healthcare now because you were told, and it's in the statute, the rock, paper, scissors game I call law, constitution, statute, regulation, and then the other stuff CMS publishes that they like that I think is, it's just paper. Statutes win, and the statute can't consider therapy. And so, Knox's whole point to CMS is, but you're considering therapy. Like, this whole math you do in here, and then it's also interesting because of they look at utilization and the number of visits. And this is another issue where I've never found out how to answer this question, but every year they cut us, and then we have to reduce expenses because we have to survive, which is the exact opposite of how a model works. Usually, in any other industry, your costs go up, you pass the cost on to the customers, and that determines the price of a Big Mac goes up when I have to start paying my employees $15 an hour. In home care, the market for our wages is going up, but CMS but we're only going to pay you, we're going to pay you 2009 rates for 2023 services, and that's not an exact comparison. And we have to figure out how to do that. But then back to our cost reports, and here's where the vicious cycle comes in. Our cost reports then record that we have found a way to do it cheaper, and now our costs go down. And then CMS goes, well, look, you're surviving. And I think one of the other things that has desensitized CMS over the years is, in the 20 years I've been doing this, I think I can count on one hand the number of years we've had an increase in reimbursement. And in every other year, the industry says we can't survive this, and yet we do. And so I also do think that sometimes CMS well, you guys always say you can't survive, but yet here we are 10 years later, and you're still all here. And so I think there's some skepticism from them. And again, because of our other problems with data and everything else, we can't show them that it really has gotten worse. The number of agencies has declined. People are getting out between what happened in the pandemic, between the regulations, and now between the ongoing downward cost pressure. I talk to agents all the time, I can't find a way to keep saying we've cut and we've cut and we've cut. We're using technology, we're being more efficient. And now there's another 5% cut coming, and who knows what else. It's hard to make that work. And we now have to make the case to CMS, and that's going to require data. It's going to require consistency. It's going to require hounding your elected officials, because I think you're going to have to get Congress involved to wake CMS up, because they think that language of statute gives them the right to come back every year and essentially rebase. And I don't know where they think this is going, because even if you wiped out the home health budget, right? If you just eliminated home health, Medicare's larger budget is not going to be that greatly impacted. We're not a huge spend. We're a huge benefit, but we're not a huge spend, which they know that. And yet here we are having this discussion about how do we get here and how do we get out of it. And there's no easy way out. I do think, to Andrew's point, I think that lawsuit has some hope. I think that the judges use. I think the DC Circuit in general has become much more skeptical of especially CMS. That the DC Circuit a couple of years back shot CMS down on they're trying to take money back based on something in a manual, and the circuit wait a second, the manual is not a properly promulgated regulation. You can't just publish a manual and take money back. So there's some hope there that they're going to recognize there are limits on what CMS can do, and in this case, CMS isn't even within those limits because they're not following what Congress said to do. And at the same time, if we can be making the case to Congress that this is a significant cut, and that the last series of pressures, if we don't rectify this and rein CMS in, they're going to eliminate or severely damage and cause significant access issues, because that's who all the patients will be hurt, because they won't be able to find home care because CMS doesn't seem to recognize the path that it's on, and that despite their data, their numbers, their ivory tower picture, the real world is beneficiaries are losing access to home care because we can't afford to serve all of them, because we can't afford to get staff, et cetera, because CMS won't pay us what we deserve to be paid for what we're doing for their beneficiaries.
Yeah,
I could go on, but I'm sure people aren't listening to me.
That's a lot to unpack, but I think what I'm hearing is we have a problem ourselves as an industry with our cost reports in terms of how we're preparing those cost reports and if they're accurate, because what we're putting together is how MedPAC is judging us in terms of what they need to do with the rates. The other thing you said was data. It's encouraging to know that the Partnership for Quality Home Healthcare, PQHH, and our National Association for Home Care and Hospice, NAHC, have both been for several years working on really good data and really trying to pull together industry data that can tell the story accurately. So we thank them, and that's really an encouraging aspect. I know Andrew Woods is using that in DC, and I know in what I'm hearing from the grassroots advocacy campaign that's around the legislation that's been proposed in the Senate and the House is that this is all about patient access, as you mentioned, Bob. It's all about, if you keep cutting our rates, we keep getting squeezed with inflation and other costs around workforce, we're just not going to be able to provide as much care as we need to the community. And that's evident right now based upon, the number of referrals that are getting rejected by the industry. We're hearing up to 70% of referrals are being rejected. Here, our agencies want to grow, right? We want to be able to have them take on more referrals, care for more people in their communities, and they just don't have the workforce. So let's try to spin this to a little bit more of a solutions-based conversation. I want to move on to Arelene. I know that we've talked about MedPAC and the preparation of the annual, reports by the providers, but let's turn a little bit to technology and what agencies can do today. Like, what are some of the actionable items that they can take today? I know you counsel agencies all the time out in the field as a consultant. What are you telling them in terms of, okay, we know we're in home care value-based purchasing, home health value-based purchasing now, and they're getting paid for value, not for volume and for visits. And then if we're taking a look down the road, maybe 6 to 8 months, if they're going to get another reduction in payment, how can they leverage whatever maybe their technology is that they're using in the office and their workforce so that they can get their feet on the ground now, so it's not such a shock for them at the end of the year and the beginning of 2024. So Arelene, what can you do to kind of give us a little bit of hope and give our listeners some tools to move ahead?
Right. Those are really good questions, Deb. And I believe that one of the first things folks ought to do is to look at the technology that they're using now. Of course, this is an Axxess presentation, and I'm certainly biased toward Axxess. We know the future of home care, healthcare is in the home, and we are doing everything as a company that we possibly can to make sure that that occurs. Many of the partners we have, and I think that that's something that operations need to be taking a look at, is what the EMR that you're using, the electronic medical record you're using, and what the company is allowing you to affiliate with. So, for instance, with partnerships, with integrations within the system, what are they allowing you to partner with? Technology is out there. The technology is going to augment the staffing issues that we have. Well, like I mentioned before, I mean, the referrals are being turned down. We have missed visits. We have LUPA issues because of not having staff. The staffing problem is not going to go away. I just did a webinar for NOC on what's called gig staffing. At Axxess, we have something called Axxess Care, where you can actually, it's almost like Uberizing staffing, where you can actually find a staff member who's close. We have PRN visits happening all the time. We have emergency visits we need to do all the time. Axxess Care is one of those solutions for that. As far as other parts of technology, we certainly have remote care monitoring. We have telehealth, and physicians are using telehealth very successfully, remote care monitoring as well. But there are also other solutions. We can now do like a six-lead EKG remotely. We can do it in the home. The patients can be connecting with their physician on an ongoing basis. We can gather that data. Part of the problem we've had as far as cost as well, and Bob knows this very, very well, are the medical reviews that we have going on, and those are going to get worse. So we know that hospice is going to be inundated very soon with medical reviews. But having that technology available and having that hard data in the clinical record is so important to be able to show why you need to be in the home and why that patient needs to be a home care patient. There's technology out there that can predict falls in a patient's home. It's not camera based, but there is technology out there. There's technology that can predict urinary tract infections for patients, like within 30 days of an infection occurring. I mean, there's just amazing things that are going on with technology. And so I think one of the partners that agencies need to look at are things like their EMR to see, again, what partners they have available that can support that. And we need to embrace technology. I mean, again, we can't do things the same way we've been doing them for the past 40 years. It's just not going to work. I mean, since 1965, home care has been in place, and since 1965, and certainly since prior to 2000, we're doing the same thing we've always done. Same way we've always done it. We've got to stop that. So we really need to take a hard look at what we're doing internally and embrace the change that's out there, embrace technology, and having the staff having that availability of that technology, so that, and those touch points with those patients. I mean, with value-based purchasing, you know, one of those things, the 30% of the payment on value-based purchasing is going to have to do with how well that patient responds to us, the satisfaction of that patient, the satisfaction of those families and caregivers, those frequent touch points that can be done. Even if we don't have the staff to do it, we can do it with technology, and that's going to be really, really important. So I'm certainly available, you know, after this webinar to talk to anyone if they want to talk about technology and things that are out there to be used. But certainly, I do believe Axxess is really on top of that, and is a really good place to start. But everyone needs to start looking at that. And again, one more thing, just to reiterate how important it is that every single one of the agency staff members, not just the agency as a whole, but agency staff members and even their beneficiaries, are sending letters to the Congress, and asking them to please stop these cuts, because the numbers of responses are going to be important. It's not just that they get a response, but the numbers of responses is going to be really important. So we need to do that very quickly. And the comment periods need to be addressed by the end of the month, I think, of August, yeah.
Right, the end of August. Thank you for that. I always love when you push the grassroots. I really appreciate that. And, you know, I echo what you were saying about Axxess and the ecosystem. I love working for Axxess, and I'm in awe every day of, you know, our product team and engineering team and the interoperability team and this huge ecosystem that's been created in terms of being able to, you know, link through the cloud to all of these other capabilities, so that agencies really, you know, can use their staff in a way that's most efficient. And we find that, you know, it's really helping people when they take a look at the full capacity of, you know, enterprise partners that we have available to them. So thank you for mentioning that, Arlene. I appreciate it. All right, I want to pivot back to Andrew Woods a little bit here. You know, we know that this is probably one of my biggest frustrations, Andrew, right? So CMS basically develops its policy making every year. You know, they put out a proposed rule in the summertime, usually in late June, and then it's followed by a final rule. And the providers have, you know, 2 to 3 months to be able to, as Arlene said, advocate, provide comment letters, you know, speak to the reasons why the proposed rule would be harmful to them personally as a provider agency, and also to the industry. And it's kind of this, I call it the whack-a-mole, right? So the proposed rule comes out, we all flurry, and everybody has to run around, and you and all of our lobbyists and advocates have to fight back and help, you know, engage Congress to push back on, you know, CMS and the administration. And then it kind of starts over, and it's just this revolving door every year. So there's got to be a better way. You've been around for many years, you've gone through this process many years, and you know, I know that you said that this is like a system level problem, and we really need a big picture system level solution to figure out how we can engage better with CMS. The government is our, you know, it's our biggest payer right now until Medicare Advantage and some of these other payers come along. But, you know, how would you suggest CMS, you know, consider Medicare, Medicaid, and Medicare Advantage kind of as a comprehensive reimbursement bundle, because we're seeing that all 3 of those payers fall under CMS's auspices. So I'm just going to throw it to you for, you know, let's try to think outside the box here in terms of how we can move forward instead of being stuck in this same routine.
Sure. Well, it's been a privilege over my career to be able to work for other settings, other sectors that had the same kind of reimbursement problems. And the common denominator, whether it's the dialysis ESRD community or the cancer community or home health, is there has to be predictability and stability in a reimbursement system. It's the way people grow their business. It's the way you're able to know how much money you're going to get paid per visit from the government, and be able to treat current patients and hopefully expand and continue to add value to the overall system, where CMS says in the proposed rule, just under value-based purchasing, CMS says home health is predicted to save around $3.37 billion from 2024 to 2027. So if you have a sector that's saving that much, why in the world, and your spend is already going down and your number of beneficiaries is dropping, why in the world would you cut it the way they are? So, you know, the skilled nursing facility a couple of years ago basically did a rebasing with CMS and said, okay, now leave us alone. If we agree to these rebasings, don't come after us anymore. And that was a deal that was cut with CMS with the full impact and influence of the Congress supporting the skilled nursing facility industry in that particular example. With regard to end-stage renal disease dialysis, we created a bundle payment, taking into advantage that reimbursement was going up and down for Epogen and other very important drugs necessary to a dialysis patient and a cancer patient for that matter. And so we came up with an alternative payment bundle, a bundle that provides for more predictability and stability for dialysis. And the arguments, unlike home health, the arguments in these other sectors are always about, once they reach more stable reimbursement, the arguments about the level of increase for those sectors in the upcoming fiscal year, not like home health, where there's no increase, but it's always an argument about the amount of the decrease. So that's why we have to go to some sort of platform that provides the predictability and stability that I've talked about. And that's really what Senators Stabenow and Collins understand. This fight is not just, oh, let's mitigate the cuts and live to fight another day. This fight, and the reason we're having the hearing, is to expose all of the flaws in the reimbursement system with respect to home health so that they can be addressed over this Congress. And hopefully, when we have the important leverage of a political election, when we have some key senators who have a lot of juice they can use on our behalf for very different kinds of reasons, we can attempt to stop the bleed in reimbursement, move towards a more predictable, stable reimbursement formula or setting, and do what the SNFs did a couple of years ago and get us out of this constant crossfire. The last thing I would say with regard to Medicaid and Medicare Advantage, look, home health doesn't have private pay. We know that for the most part. If there's any margin that's made on fee-for-service, and MedPAC said this year it's going to be about 25%, and dropping just under the proposed permanent adjustment cut of the 7.83% that's now gone up, they said next year the fee-for-service margin would decrease to around 18%. Whatever the margin is, we have to have some sort of cushion on the fee-for-service side to be able to take care of Medicare Advantage and Medicaid patients, because those are money losers for any company. You're just not going to make money on them. And so as part of this hearing we're going to do in September, even though CMS says we never, ever think outside the box with regard to Medicare Advantage and Medicaid with respect to what we pay Medicare fee-for-service, because it is not, Medicare fee-for-service is not intended to be a subsidization of Medicare Advantage or Medicaid. Well, they can say that, but if you take away whatever margins we have, reasonable margins on fee-for-service, we can't treat those Medicare Advantage and Medicaid patients, which is what Democrats and Republicans want us to do. They want more people in Medicare Advantage for various reasons. Last point I'll tell you is, I mentioned the meeting with Senator Collins. Before I went to Maine, I went to New Hampshire, and I was with Maggie Hassan, senator from New Hampshire. Very strong home health champion. Senator Hassan has a son who has cerebral palsy. He sits in a wheelchair. He can't move his head, can't move any of his limbs. He can blink his eyes, and he can't communicate. And she fights every day for Medicaid benefits, in particular for people like her son. And so she pledged to me in the beautiful White Mountains of New Hampshire, even though it was raining on Saturday, that she's absolutely in this fight, 100% supporting Debbie Stabenow and Susan Collins and all the other members that are going to get on these bills for people like her son, Ben. Because if it wasn't for the home health services provided by Interim, one of the member companies of PQHH, Senator Hassan wouldn't be able to serve in the Senate and work on these issues on our behalf. So a lot of members of Congress who are touched by home health and are tired of seeing us as providers on a roller coaster of reimbursement and are fighting not for the big companies, although we all love LHC and Medicare and Axxess and all the rest. They're fighting for the smaller providers, and they're fighting for people like Senator Hassan's son, Ben. That's going to make a world of difference in this fight, just like when Medicaid beneficiaries came to Washington and taught members of Congress what Medicaid was all about when there were attempts to repeal the Affordable Care Act and cut Medicaid services drastically. So as I said before, Billy Tozan said it best, we're respected but not feared. I think we have to get Congress and the administration and CMS to better understand the range of services, better understand the savings that we generate for our system, that we need a more definite, permanent, objective payment system like the other sectors have gotten. We deserve that. And that this constant bloodletting on reimbursement has to stop.
Thank you, Andrew. That's a perfect way to wrap the end of this webinar. We're just at time. We've spent an hour together and it went by really quickly. I really appreciate the work you're doing with members of Congress. I appreciate everything you're doing, Arlene, out in the field, and Bob, you with all of your clients and making sure that they're doing what they need to be doing in terms of filing their cost reports appropriately and taking a strategic look at their business model. So I just want to thank all of you, Bob Markette, Arelene Maxim, and Andrew Woods, for participating in our webinar today. And then thank all of you for joining us. Please look for an email early next week, probably Monday, with a link to today's recording. And also we'll have an Axxess landing page with CMS tools and resources for you so that you can ensure your own success in understanding this proposed rule and what this might mean for you. So if there are questions in the chat, the panelists will take a look at them and we'll get back to you individually by email. So for all of us on this webinar and for Axxess, thank you so much for joining us and have a wonderful day.
Thank you for joining our on-demand training today. Axxess is the only home healthcare technology company approved by the American Nurses Credentialing Center to offer continuing education credits and the most recommended home health software on Software Advice. You can watch more on-demand training videos through our industry-leading help center or at axxess.com, where you'll find tutorials, blogs, white papers, and answers to frequently asked questions. Axxess, empowering care anytime, anywhere.